Thank you very much. I see Jordan, who extended the initial invitation in the organizing committee. Not sure how Jordan convinced me to leave 75-degree sunny weather for this, but I actually grew up in upstate New York, so I'm returning to my old weather patterns. Well, today I want to start the clinical session with a very high-level view of what's happening with the current real-world experience for these new DAAs, and I think if you're going to take a nap, you can just take the final conclusion is that these drugs are very different than what we're used to, where drugs have never correlated with the clinical trials. And I think as you see the accumulation of data, it's pretty impressive that these new oral inhibitors are really translating into the real world. So these are my disclosures. So overall, I'm going to talk to you about a observational cohort that I've been involved in for the last 5 years. I'm going to talk through some of the efficacy and safety of the current regimens throughout the real world. And I'll talk to you about really the more relevant drugs. We have a cohort of over 8,000 patients, but as you'll see, we're just going to talk about the ones that are most important that are currently regimens in use. And then I'll break down some of those different treatment regimens. In general, as you know, there's a tremendous amount of data on whatever gets used in clinical practice. And because for at least the US and Western Europe, sofosbuvir and ledipasvir has been the most commonly used drug, I'll show you some pretty extensive data on clinical decision points around treat patients for 8 versus 12, shorten therapy from 24 to 12. So I think some clinically important data that has not been answered by clinical trials. And then I'll end with some data on genotype 2-3. And genotype 3, as you'll see, is really the only true unmet need, I think, around drug discovery. And then I'll even show you some special populations. Again, all real-world data. So why do we care about real-world data? Well, I think there are a lot of benefits. We learn how these drugs really behave in the hands of prescribing clinicians and patients. Patients in clinical trials are very narrow in who gets studied. Patients in the real world are heterogeneous as well as their prescribers. Patients are not as carefully screened, treatment's not as carefully monitored, and therefore we get a real reflection on the flexibility of these regimens. And I think trials are short and real life has no time limit. These cohorts allow us to look at really important questions to patients. What happens after I get cured? Not just is the virus gone, but do I feel better, feel worse? Do I still get cancer, et cetera? So I won't show you the long-term follow-up data because that's still under evaluation, but I'll show you a lot of the short-term cure and safety data. So this is our international registry that looks at a series of university and academic sites throughout most of the United States, North America, Toronto, and then we've gotten a number of sites in Western Europe with plans actually hopefully this year to spread into Asia. So we're really trying to develop not just single center specific data, but either national or even worldwide database looking at heterogeneity of patients and regions. So you've heard that we've got a plethora of new drugs. And this is really amazing if you think about what's happened in the last decade, that we currently have 7 oral approved therapies for hepatitis C, and then the 8th one coming this summer. So we have a whole series of regimens that look at different DAA targets and combinations. And in general, you'll see that the majority seem to work in similar fashion. I will not focus on some of those that are not being used in our current cohort sites. So I'm going to start with looking at sofosbuvir and ledipasvir, which is the most common drug used, at least in North America. And this just looks at big picture of a little bit under 1,000 patients. And what happens to those genotype 1 patients? You'll see cure rates are 95 to 97% across all cohorts. If I put up the clinical trial data next to them, they wouldn't show much difference. So again, these are pretty big numbers, bigger than have been reported in clinical trials. And most treatment failure is relapse, and relapse rates are very low. At least in HCV targets hands, the tolerance and compliance of these medications has not significantly impacted outcomes. In other words, we don't really see breakthroughs in thousands of patients anymore. Pretty much everyone fails. They fail because they're going to relapse. Now, there are some exceptions to that rule, but relapse is the major cause of failure and not virologic breakthrough. So if you look at some of the subgroups within this large cohort of patients, you'll see there are still some advantaged and disadvantaged populations. If you look at a cirrhotic versus non-cirrhotic population, in the orange box, you'll see there's still about a 5% lower cure rate in the real world if you're cirrhotic. You'll see if you look at genotype 1A versus 1B, 1B is easier to cure than 1A. And if you look at the biggest difference is really in decompensated patients, where it's better to have compensated cirrhosis than decompensated, even though an 87, 88% cure rate in a decompensated cirrhotic is unbelievable, it is still about 10% lower than a patient who doesn't have compensation. And then a story that we recently reported that I'll share with you a little bit more, actually, which is a new finding, people who were taking an acid blocker at the time of using this medication had a lower cure rate. And there's good rationale for that. So if you look at the baseline predictors, so those were the virologic and demographic, you'll see that overall, it's typically what we think. Healthier people do better. People with higher albumins, higher platelet counts, people who don't have cirrhosis, and if you do have cirrhosis, that it's compensated. And so you can eventually start to choose patients that are much more likely to respond. But again, when you have total cure rates approaching 95 to 97%, these are only statistically significant because of such large numbers of patients. So the clinical relevance is there, but it's a small clinical relevance. So we wanted to try to answer the question. If you look at the label, at least in the US, for the use of Harvoni, it says patients with HCV RNAs who don't have cirrhosis, who have a viral count less than 6 million, may be considered for 8 weeks of therapy, based on very few patient data and a sub-analysis that came out. And so what happened in the US is that a number of payers immediately mandated 8 weeks because it saves a lot of money. But the great thing about real-world data is physicians and patients and clinicians do what they want. And so you end up with a distribution of some physicians that chose 12 weeks and some that chose 8. And so we were able to grab a group of a little over 300 patients who all qualified and looked very similar to the population who could have received 8. You can see early on the majority of us were not using 8 weeks. But if you then track their outcomes, you really saw that the 8 versus 12 week didn't really appear to matter. And at least in this population, 8 weeks was just as good as 12. The other thing that a lot of clinicians do, even though there's no data to support it in the clinical trials, is base a decision on how long to treat, like the old days, response-guided therapy. Check a virus at week 4. If it hasn't fully cleared, there's no way they could stop at week 8. Therefore, I'm going to go longer. I think that's what's in clinicians' mind, and it's because we, for a decade, have been using response-guided therapy. In the box here, what you'll see is the patients who got the 8-week regimen and the 12-week regimen, and for the physicians that did check a week 4 viral load, what happened to those patients? You'll see that 7 out of 7 patients had quantifiable virus at week 4. They finished 8 weeks, and it's anecdotal because it's only 7, but all of them were cured. And you'll see basically that it didn't really matter if your virus was below quantification or undetectable. Or quantifiable. And so, again, and it's been looked at in huge numbers of patients across all the clinical trials, for some reason, with these DAAs, early viral kinetics, or at least at week 4, there is some data that maybe week 2 or earlier may help differentiate. But anyway, so some interesting data that argues against using the week 4 viral level to make a decision on duration of therapy. So the PPI issue was interesting. I won't show you the data, but the database has actually people who are on acid blockers or PPIs. Both had the same effect. And so we did an extensive number of analyses. This is just the overview, looking at both the 8 and 12-week regimen. And what you'll see is that patients who were taking a PPI at the time they initiated their Harvoni prescription had a lower SVR. Now, overall, this is still incredibly high SVR, but this is a very modifiable risk factor or aspect. And again, with this drug, the NS5A inhibitor needs an acidic environment to be absorbed. And the thought is, and even in the drug's label, it's not really called out. In the drug's label, it's like, well, you should lower the dose of the PPI or try to get them to switch. But in real world, it's clear that people didn't take this too serious, and it has some impact, but again, it's a modifiable one. So again, this is really nice data that comes out of routine practice that I think is very important to educate all of us that, you know, these are modifiable factors that we can talk to patients and either get them to stop the PPI or appropriately dose it so it doesn't impact with absorption. So one of the other major issues right now, and these are mainly unmet needs that I'm showing you, is that right now in North America, for a treatment-experienced cirrhotic patient, the guidelines suggest 24 weeks of therapy. There have been a number of small studies, usually of 40 to 50 patients, showing that you can shorten that patient to 12 weeks with sofosbuvir ledipasvir. And again, we just observe what happens in the real world. The majority of patients were given 24 weeks of therapy and without ribavirin, which is again the drug's label, and that population, large population, had 95% cure rate. There are patients who had ribavirin added on. Typically, these are ones that the physician thought were harder to treat, but overall about the same effect. So it didn't appear to be a benefit of adding ribavirin. Interestingly, those who shorten therapy, if you're going to shorten therapy, the recommendations are add ribavirin. That appeared to continue with a very high SVR rate of 97%. But for lots of reasons, life also intervened, and a number of patients were treated without ribavirin just for 12 weeks. And if you go back and look at some of the clinical trial data, I think there is still a lot of question about, do we need 24 weeks? I mean, this is a lot of money saved. So again, these numbers aren't big enough to make a firm conclusion, but what you see as these numbers accumulate, there's a push to say, 8 weeks is okay in the easy-to-treat population, and the hardest-to-treat population, it looks like 12 weeks is appropriate. And that would have enormous healthcare savings if we were able to make those switches comfortably. So you've seen, at least with this combination, lots of high cure rates. This just shows you in a little bit under 2,000 patients what the side effect profile looks like. This is actually also similar to clinical trials. Fatigue is by far the most common. Headache sits right there with it. And no other real AEs rise to the top of the list. I will say that the amiodarone story was supported out of this database. And so there are some rare events that can lead with these big databases to understanding new drug toxicities. But overall, I think HCV target so far with at least Harvoni has suggested that the clinical trial backs up a very low adverse event rate. Okay, so genotype 1, the earlier discussion, is there really a need for drug discovery? I think the answer is no. Most patients are going to have above a 97% cure rate if given the drugs appropriately, and it's a cured disease from our perspective for those that can actually get it and access the drug and pay for it, and all the other issues that are actually becoming more important now than drug discovery. So I'll quickly move into genotype 2 and 3, where there's a little bit different story. In this slide, I just showed you the target population of genotype 2 and 3 patients, both an intent to treat and a per protocol, which is probably more fair for registries, where if people are lost to follow-up, you don't include them, but for the sake of transparency, showing both. And what you'll see is that genotype 2, the real world, sofosbuvir plus ribavirin, looks fairly close to the clinical trials. Again, though, here we're looking at least 10% of patients who fail through relapse. However, genotype 3 is a very different story. The Valence trial was the last of the phase 3 trials and had mainly done in Europe and had suggested that genotype 3 soft ribo was a fairly good regimen. I think quickly people found out in North America that there was almost as much chance to fail as there was to succeed. And now retreating those patients is a huge problem for us in the US for insurance reasons. But if you look at the genotype 2 breakdown of the different populations, you'll see, most treatment failures in 2-3 are relapsers. So actually, the hardest to treat patient is a naive F4, so cirrhotic, and the treatment experience for genotype 2 respond fairly well, but a naive mild fibrosis does really quite well with sofosbuvir ribavirin. So overall, not too bad. There are certain populations that are below this 90% mark that we have to hit, and I think now we're all pushing that to 95%. Genotype 3, though, was the dismal failure, at least here, and what you'll see, I think, is that there are populations in the treatment experienced group who have cirrhosis where the majority of patients, almost 50-60% are failing. And so this is what we all saw. We threw these drugs into the sickest people, and for this population, here's where we need new drug discovery. Now, there's lots of other real-world data, and in this case, Bristol Myers did not do the best series of studies to say how best to use their drug with declatosphere and sofosbuvir, and so the rest of the world actually filled in the gaps. And here's just one piece of information from a compassionate French program that shows you, for this G3 patient who's has cirrhosis, that you're better off extending therapy to 24 weeks. And these types of actual real-world data are what have led to the guidelines, because this study was actually never done by Bristol Myers, 12 versus 16 versus 24. So, and there are a lot of other examples that are out there where new combinations of drugs, drug labels or guidelines are mainly being based on real-world data. I think for the first time, I'm on the World Health Organization committee that's setting the new guidelines that were just released last week at Apostle. And for the first time, even the WHO assembled the world's real-world data and included it in their analyses, because interestingly, sometimes there's more data from the real world than there is from this rapidly evolving quick fix to get a drug approved and move on. So without spending a lot of time, for decades, special populations were very hard to treat. There's a lot of clinical trial data to say there is no such thing as a special population anymore. And I'll just show you a snapshot of what we consider special populations, and this is real-world data, not clinical trial data. HIV co-infected, liver transplant, kidney transplant, and then a group we just called any solid organ transplant. This data will be presented in a few months in Spain. But in general, we are almost looking 90% and up in almost all of these challenging populations. And now with the approval of the Merck regimen, even the kidney failure patients who were the last special need population now will have SVR rates above 95%. So again, these drugs appear to be special and deliver at least in a North American, Western European population. The other thing that is the most impressive in my mind, to look at safety of drugs, to me the most important clinical relevance is discontinued prematurely. And if you look at the clinical trials for all of these drugs, they're less than 2%. And so far, if you look at almost 3,000 patients with these newer generation drugs, it's still less than 2%. So again, I think these drugs are being put into some very sick patients. I didn't show you that 20% of our population that I showed you the data in are decompensated patients. And so these drugs are fairly safe and can be applied to fairly sick and broad populations. So I think overall they've held up very well. So in summary, I think the real world data has been consistent with the phase 2 and 3 studies. If I'd given you a talk 2 years ago and showed you our first version of Target that looked at telaprevir and boceprevir with PEG and RIBA, it was the exact opposite. We were 20% below cure rates in the real world and a massive increase in side effects. So getting rid of ribavirin has really allowed these drugs to be applied with high efficacy and really minimal safety issues. I think genotype 3 is clearly the unmet need. I think this summer, with the approval of valpatisvir, a lot of that unmet need will be met. we're seeing very high cure rates in the real world. There's still an impact of cirrhosis, and there's still an issue with decompensated cirrhosis. And there's a huge discussion around when is it too late to treat, and should you transplant people earlier and not cure them and leave them in this limbo where they're cured, they'll never get a transplant, but maybe haven't gotten better. So there's a really interesting discussion around ethically when's the right time to treat in that decompensated patient. Our data would suggest that 8 weeks is underutilized, and we've been encouraging. Most of our docs in the networks have all kind of been shifting because the data speaks for itself. PPI use, although it clearly leads to decrease for Harvoni, it's a modifiable factor and is something that we're trying to push a new education message. So get those 83s up to, or 93s up to 98. And I think the safety, as I described, has really been quite remarkable and not what was seen with the first generation DAAs. The big limitation of this kind of data is that these are not head-to-head comparisons. There has not been a head-to-head comparison of any of these drugs that I've shown you done in the world, and there probably, well, there may not be, but at least in the US, PCORI, the Patient-Centered Outcome Research Institute, just funded a $16 million trial that will start next month. And they're going to look at a real head-to-head comparison of these drugs, which is important, I think, for many reasons, very patient-centered. But most importantly, it's going to look at long-term outcomes, cancer issues, disease progression, and the patient-reported outcomes and functional status. So we give PCORI a lot of credit for funding such a big trial, which doesn't occur very often in the Hep C space, a big clinical trial like this that's not pharma supported. So in conclusion, I just want to acknowledge this is a huge number of people. Jordan and the University of Toronto here, I think, have allowed us to claim North America. Thank you. But there's a lot of people, a lot of sites, and most importantly, patients. Now 8,000 of them who have signed consents to say, yes, please follow my data, and if you can learn from it, great for me and great for the next one who comes. So I thank you for your attention.
Thank you very much for an excellent talk. I think it's really exciting to see such large numbers of real-world data presented and stuff we may never see from clinical trials. One of the concerns, I guess, we have with Target is given the restrictions in the United States, particularly around substance users accessing hepatitis C treatment because of restrictions, particularly by Medicaid. How many active substance users, injection drug users are included in Target, and can we expect to see real-world data in this population coming from Target? Because I think it's very important to have that data to inform policy.
So it's a fantastic comment. We have tried beyond belief to enrich HIV patients and PWIDs, and it has been impossible for multiple reasons. The HIV patients are actually all being treated in clinical trials, and very few are actually getting treated in the real clinics. And as you know, in the US, it is almost impossible to get somebody within 6 months of having used any IV drugs, alcohol, et cetera, onto one of these medications. There is a major trial that's launching in New York, another PCORI-funded trial, that's going to focus on a couple thousand patients and look long-term at what happens to them in terms of reinfection rates, mainly looking at baseline resistance and its impact and how the virus changes on reinfection. So there are some databases coming, but Target is not going to be able to answer any of these really unusual populations that can't enter clinical care. Because again, this is clinical care. You have to enter clinical care and get an approved prescription. And so that's why some of the real populations of interest at this meeting are not represented.
Thanks, Dave. That was a great talk. Thanks for coming up from Florida. Much appreciated. So you made a comment about the underutilization of the shorter treatments, and I think we've struggled with the same thing, that from an economic sense, it totally makes sense to shorten treatment, and I think you've nicely shown, and others as well, that the shorter treatments work. But I think the challenge as clinicians is we always struggle with the fact that payers won't let us retreat people. And so we always worry that for that individual person is the shorter therapy. You're definitely right, in aggregate it may not make a difference, but for the given individual, it might make a difference. So how do we get payers to recognize that the economic sense is clear that you should treat people with the shorter therapies and then retreat the small number of relapsers? But I think that has to change first before you're likely to change clinical practice.
So I agree. I'll provide a comment first and then maybe a coming solution. As a patient advocate, not as interested in saving money in the healthcare, I would in myself, if I had Hep C, always take 12 weeks because it's safe and the cure rates are close to 100%, and there isn't enough data, and there won't be that clinical trial that's well randomized. So and as a physician, we always err on the side of the patient. I think that's what the Hippocratic Oath is. But when you take a policy look and how we can't treat so many other people, we have to try to increase, we're over-treating 90% of people in the 8-week as well as probably the 12-week regimen. So I think at least in the US, there's something called a commitment to cure, where you're getting reimbursed for a cure and you're looking at outcomes as opposed to expenses and intervention. So at some point, an insurance company will pay so much for a cure and they'll have to guarantee that cure. And I think, outcomes, at least in the US, is probably catching up with Canada, but we're now getting paid for outcomes and not procedures. GI docs, instead of getting paid to do, to do transplants, are going to be getting paid to try to cure Hep C and Hep B and prevent transplants. It's a crazy system that we're moving into, which will be hard for the US to adapt to. But right now, there is no easy answer. The payers force 8 weeks. And then as soon as you find the ones that don't respond, they come back and say, well, you can't retreat them because they've already been treated. But I think that's changing. But the payers they're just to make money, right? Unfortunately. So they know how to do it well.
Thanks.
So.
Thank you. Any other quick questions before we clue up for the coffee break? No? Thank you very much, Dr. Nelson.